Assalamu alaikum. Starting the long clinical consultation today, we have Mr. Ainat, 28 years old, complain of headache and fatigue for the last 2 months. Vitals are normal. We start at the timer. Yes, you can see the timer. You can start now.
Okay.
Okay. Okay. Uh, Hello, sir. I am Dr. Ali, one of the doctors in this clinic today. Are you Mr. Imad, 28 years old?
Yes, doctor.
Mr. Imad, today I got a letter from your GP that you are suffering from headache and fatigue. Is it?
Correct.
Okay, can you tell me more about your health condition, please?
Yeah, doctor. Thank you. Actually, doctor, I have headache. It's for the last 2 months, and it's increasing, doctor. And I'm an
Mm-hmm.
office manager, and it's really affecting my life. And with this headache, I also have a weakness, like I have a no
Mm-hmm.
energy. And
Mm-hmm.
I don't know. They started the whole started together. I don't know what the problem.
Mm-hmm. I am really sorry, Mr. Ahmad, what happened with you. And
Mm.
today I asked regarding your all the history, and I'll do some examination, and later we will ask about that solution. Is it okay for you?
Thank you. Thank you.
So, Mr. Ahmad,
Okay.
as you said that last 2 months you're feeling tiredness, loss of energy with the headache. So, is
Yes.
it started suddenly or by gradually?
I think both started gradually, the headache and loss of energy.
Both are gradually. Okay. So can you tell me that how much grading of your headache? If 0 is the lowest and 10 is the highest,
I give it 3 or 4.
3 or 4. So do you always feeling headache like all the time or there is any specific time?
I noticed that the headache is more in the morning, doctor.
Mhm.
Mm.
Is there any problem in there in sleeping in the night time? I mean, is there any snoring in the night your partner said or something?
Yes, correct, doctor. My wife told me that I have a snoring, and
Mhm.
sometimes I wake up suddenly at
Mhm.
night looking for a fresh air. Yes.
Mhm. I understand.
Mm.
With that headache and snoring, do you feel that your weight is increasing?
My weight is all right, doctor. I'm even I can call that I'm thin.
Mhm.
Yeah.
Can you tell me how much your BMI, if you know?
I guess it is like a 19 or 20.
Sorry,
Yes, 19 or 20 might be a month.
19 or 20. Do you feel
Yeah.
that your neck circumference, I mean, diameter of the neck also increasing?
I'm not sure, doctor, but I think I'm all right. My weight is
Mhm.
stable. Yeah.
Okay. So what you feel that your headache increasing by what? Is there any factor for increasing headache?
No, nothing like increasing my headache. I just wake up
Mhm.
in the morning with this headache.
Do you feel any relieving factor? I mean, any painkiller or something you feel better?
Um, Nothing, just it improved during the day.
Okay. So do you need any painkiller now as you are talking with me? Are you now stable?
No, I'm not taking any kind of a painkiller.
Okay. Okay, so I just want to know, as you said, that fatigue and loss of tired, like less of energy, is it related with something? I mean, when you are doing more work, you feel more tired. Is it like that?
No, it's not like that.
Okay, how you get relieved? Is there any factor like if you take rest, you feel better like that?
I just like improve during the day. This is
Mhm.
the thing that improve my headache and also the fatigue.
Okay. So can you tell me actually which time you feel more fatigueness, like morning time or night time or evening time?
I'm seeing the morning time.
Morning time you have more fatigue, more
Yeah,
tiredness.
yeah.
Okay. So in the evening time you are feeling better. Okay,
Hmm.
so I just want to know that with that headache, do you feel anything problem with your vision?
Actually, doctor, I'm wearing eyeglasses since the age of 7.
Okay,
Yeah.
okay. Is there any recently changes of your eyeglass power for some issue?
No, no, it's all right.
Okay. Do you feel anything like over secretion from your eyes or from your nose?
No, no, no,
Is there any
no.
problem with feeling of throwing up, vomiting,
Um,
I mean?
actually, no, doctor. No.
Okay. So, do you any under any stressful condition, I mean, any familiar or job related any issues you have
I'm,
under any
I'm, I'm,
stress?
I'm very all right, doctor.
Okay, okay. So I just want to know that as you said that you're sometimes taking medication. Do you take any type of the other medication? I mean, any recreational medication, if you don't mind, or any other type of the medication?
Yeah, actually, doctor, I'm taking kind of a medication called the beta blocker.
Hmm.
It's a
Okay.
for heart problem that I don't know. Really
For how
what
long?
my heart problem, but I'm taking it. Yes,
For how long and how much its dose?
is for the last 5 years, and
Hmm.
I think I'm taking like 2.5 milligram of bisoprolol.
Okay. So for what purpose actually given this medicine? Can you know? Can you tell me please?
I think it's something in my aorta.
Sorry,
In my
something?
aorta, I think
I don't understand what you say, please.
it's something in one of my great blood vessels, doctor.
For your blood vessel problem. Okay, okay, I understand your point. Okay, so I just want to know that except that beta blocker, are you taking any other type of the medication?
Sorry, what you said, doctor?
Are you taking any other medication except the beta blocker?
No, doctor. By the way, I
Okay,
shared the photo for the patient on the group.
okay,
Yes.
okay, okay, okay. You can share, please.
Mhm.
Okay, so I just want to know, do you have any other long-standing disease?
Actually, doctor, I am adopted,
Okay, okay, okay,
and
okay.
yeah, I don't have like a great follow-up breeding.
Mhm.
Yeah.
Okay, 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 okay. I just want to know that do you have any other past medical history? I mean, any surgery history or something?
I have a recurrent um, uh, like an air around my lung. I think it's called like pneumothorax. Yes.
Pneumothorax. Okay, okay. So
Yeah.
you have recurrent pneumothorax history. So did you did
Yeah.
any surgery or any taking any medication for pneumothorax?
I am planned to do something called, I am planned to do something. They told me like a kind of a scope or something. I'm gonna do
Mm,
it.
Okay, okay, okay. I understand. Okay,
Yeah.
so I just want to know that what's your profession, please?
What's what?
What's your profession? What you are doing for living?
Just can you hold a minute, the meeting, Dr. Basim, just a
Okay,
minute.
okay.
Yeah, sure, Dr.
مم. عشان معلش أنا عندهم الدكتور يعني مثلا يجيب لي اسهم زبادي نادي عشان رايد كده، يجيب لي ثلاثة، عشان حامل شنو كمان حامل عصيدة وملح. Yes, hello. I'm sorry for that.
Yes, yes,
Yes,
yes.
yes, we can
Okay.
hear you.
Yeah.
Okay, so I just want to know some other things, Mr. Imad. Do you feel any other problem with your like difficulty to talking or difficulty in the speech? Anything problem related with that?
No, 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 not really.
Do you feel in terms of weakness of your parts of the body?
Weakness? No, doctor.
Any changes in your sensation?
No, doctor.
Any problem with your vision?
With my vision, yeah, I'm wearing an
Yes.
eyeglass since I
Okay.
was a 7-year-old.
Okay. Do you feel any racing or pacing of your heartbeat?
Actually, yes, doctor, sometimes. This is the past, and that is
Mhm,
why, like before 2 years, I
mhm,
was following up with a heart doctor, and they give me this
mhm.
kind of medication.
This medication. Okay. Do you feel associated with the chest pain?
No, doctor.
Any problem with the breathing difficulty?
And this in the past when I get this air around
Mhm.
my lung, and
Okay.
they managed in the emergency.
Yes, yes. Do you feel any problem with the tummy distension?
Not really, doctor.
Any tummy pain?
No, doctor.
Any sweating?
Not really.
Okay. Any changes in your water work? I mean, amount, color, frequency?
No, doctor.
Any changes of the bowel work? I mean, constipation or loose stool?
No, doctor.
Any joint pain or stiffness?
Uh, Actually, I have a joint pain in my both ankles, doctor.
in, in the both ankles. Is there any swelling you saw before?
Sorry, what you say, doctor?
Is there any swelling there?
No swelling, it's just kind of a pain.
Okay. Did you get any trauma, injury? That's why
No,
swelling like that? Anything?
no, doctor.
Okay. Okay. So I just want to know, do you have any type of the bleeding tendency from any parts of your body?
Not really, doctor.
Okay. So I want to know that what you are doing for living.
Actually, I am a master student, doctor. I'm doing my
Must have
master degree in fine art, yes.
how much it's affecting your daily life in certificate and headache.
Actually, a lot, doctor, because I need to concentrate. I have upcoming
Mhm,
exam. Yeah.
mhm,
And also,
mhm,
I'm also, and I said before, I'm office manager.
mhm,
Like, yes, I'm
mhm,
doing like two job as a part-time.
mhm. Okay,
Yeah.
Mr. Rema. So regarding that issue, we can provide you sick leave, and we can also arrange with your occupational health worker for your office
Wonderful,
purpose.
wonderful.
Maybe they can help you.
Great, great.
Okay. So I just, Mr. Rema, I need to examine you. Is it okay for you?
Please, doctor.
Before that, I need to ask you, do you smoke?
I stopped smoking, actually, doctor.
Okay. And do you take alcohol?
No, I'm not drinking.
Okay, that's good. So first of all, I will start from the hand examination. Is that as the vital sign is normal, pulse, blood pressure normal, and is there any hand changes, hand swelling or something, sweaty hand
I,
or hand swelling?
okay, I will post the hand picture
Mhm,
in the group.
mhm. Even you can tell
Yes,
me, no
there
problem.
is like
Mm.
a long fingers.
Okay, long
No,
fingers
yeah,
in the hand. Okay, so I need to check height, weight, arm span. I mean, I need to check arm span. Arm span is longer than the height.
yeah, arm span on the height more than 1.05.
Okay, I need to check that thumb sign and wrist sign. Is it
Both
positive
are
both?
both are
Both
positive.
are
Yes,
okay. I hope there is also dactyly. Anyway,
yes,
so
yes.
after that I need to go for any type of the muscle weakness, functional myopathy.
No, no muscle weakness.
Okay. So I need to go for eye examination. Can you see my finger? I mean, Snell's chart and visual acuity. It's normal or not normal? Visual acuity.
The patient is wearing his eyeglasses and
Okay.
visual acuity is normal with eyeglass.
Normal. Okay. So I just can you remove your eyeglass, please? I need to check that pupillary eye reflex. Is it okay, pupillary eye reflex?
Yes, both are
Okay.
okay.
Then I need to check that H-shape movement. H-shape movement, I need to check. And also, I hopefully,
Normal.
and what about the lens position, lens upward or downward, dislocation of lens, anything?
Mm, skip it.
Okay.
Mm.
Then I also need to check about the fundoscopy examination. And after
Great,
that, I need to,
great, skip it.
okay, okay, I need to check any mouth, any high arch palate, any
Yes, very important.
long internet, okay, high arch palate, interdental space, I need to check. Okay, I
Yes, there
need
is
to check any,
crowding of the teeth, and there is
mhm,
palate, and there is like a
okay,
small jaw, like retrognathia.
a small jaw,
2 minutes
okay.
remaining.
Then I need to see that any neck swelling, if there is a no neck swelling, okay, I need to go for chest examination, chest movement, expansion. I need to see any added sound at the chest. Hopefully, here breath sound will be reduced as there is history of the pneumothorax. Maybe breath sound will be reduced, and I need
Like
to
there
check
is
any added.
chest examination now is
Yes.
normal, but there is a
Mhm,
scar for the previous train for the
mhm.
pneumothorax.
Okay, it's the right or left side?
Say right.
Okay, right side. I need to see that the auscultation of the heart, like any murmur, especially for mitral valve prolapse, aortic regurgitation, mitral regurgitation, and heart sound. Is there any murmur?
There is aortic regurgitation, Merve.
Okay. So I need to check for the also for the back, if there any like basal crepitation, and
No
also there
basal
is a
regurgitation and no
apex
sacral
beat.
edema.
Okay, no sacral edema. Apex beat is normal in position, I think.
Yes.
Then I need to check the leg if there is a leg any wasting or weakness or something.
Mm-hmm.
And I need to palpate the abdomen if there any organomegaly or not, any abdominal tenderness or not. Then I need to
No.
check the gait. Can you walk for me, please, Mr. Remat, for some time?
Yeah.
I
The
need
gate
to
is
check the
open.
gait and I need to check the leg and then the slight leg swelling. I need to palpate and I need to move to see any tenderness for movement. So, Mr. Ahmad, I already take history from you and I did examination.
Yeah, what's
Can
the
you tell?
problem, doctor? What I have, doctor? Why I'm getting this
Okay,
morning headache?
okay. I highly appreciate your concern, Mr. Ahmad. So, what I feel from your history and from examination, I'm thinking this is one type of the your muscle and bone related disease. We are calling it Marfan syndrome. Do you heard about that?
Actually, I think I'm here, but no one explained to me.
Okay. This is actually one type of the disease, familiar disease is run from generation to generation. And it's actually there is something defect in your protein and chromosome. That's why there is a abnormal movement of the muscle and joint and abnormal activity, I mean hyperactivity and elasticity will be increased. That's why your hand, your legs become enlarged in the size and it will affect over your heart even over your lungs as you have history of the pneumothorax and also even it can affect over your vision and that's why you can feel that headache and tiredness all the time because it's overall affect over your heart, lungs, eyes, joint and overall
Mm,
activities. So
mhm.
are you getting my point?
I'm with you, doctor. Please.
Yes. So this is one type of the chromosomal disease, and I mean familial disease. So in that case, we need to do some genetic test. We are calling by genetic blood test. We need to send you the genetic counselor. Will involve the genetic doctor and specialist nurse and physicians, and also we will involve that heart doctor, lung doctor, and eyes doctor for
Mm,
to overall your checkup and actually, it's a mainly supportive treatment we'll give you, and we'll do at the same time some blood investigation and some imaging test of your heart,
mm.
lungs, eyes, and some blood test. Are you getting my point?
All right, doctor. And what about my headache and fatigue?
Yes, I highly appreciate. We'll involve a mood doctor, so they can also help about the mood, and also we'll involve a physician, and maybe we'll give you some painkiller and sick leave, and we will further assess blood investigation for any other abnormality or not. So we will later solve according to your blood results.
Sure, doctor. Okay, thank you.
Welcome. Thank you.
Okay, let's start examiner time. Please, Dr. Rhoda.
Okay. So, what are your differential for this
Uh,
man headache and fatigue?
well, this is 28 years. Mr. Imad came with headache and fatigueness for last 2 months, and which is mainly in the morning time, and there is a no history, and he looks like his BMI is normal and vital sign is normal, but there is actually influence that height and arm
Mm,
span, and also there is a I found there is a wrist sign and thumb sign positive and arachnoidectomy, and also there is a vision problem from the childhood. That's why using eyeglasses. History of the pneumothorax, which is treated by the chest brain, and also there is a I found on the cardiac examination there is a aortic regurgitation murmur, and also there is a he's taking beta blockers for a long time. It's probably due to from his heart condition, and also there is some leg swelling. So overall my history and from my examination, what I'm thinking this is a case of the Marfan syndrome.
So, what could be the causes of headache and fatigue in this patient with Marfan syndrome?
Well, in the Marfan syndrome cases, it's can be there is actually cardiac impairment, and there is a valvular heart disease. This is the one
Mm,
of the cause, feeling
mm,
fatigueness, tiredness, and maybe there is a so related with the anemia. That's why
mhm,
feeling headaches, and also maybe there is a mood disturbance as
mhm.
really affecting his life. So this is another cause of the headache and fatigueness, and
Yeah,
also there is a
mm. Yeah, I'm with
and
you. What
also there yes and also there is a previous history of the chest drain, so it may also affect over his mood in the surrounding overall his physical structure. Maybe it can causes its maybe he's like psychologically depressed or something. That's why he feel more headache, tiredness, fatigueness.
okay? So, what are the respiratory complications that could patient with a Marfan syndrome present with?
In the Marfan syndrome cases, usually the patient there is a coming with there is a pneumothorax because there is a high chance of the pneumothorax.
Yeah, what else apart from the like if
Uh, uh,
apart from the
apart
pneumothorax?
from apart from the pneumothorax, is there is if only going for the pulmonary condition, pneumothorax, repeated chest infection can happen. Uh, I think these are the two are the most important.
Oh, okay. So, this patient, how you are going to investigate for his headache and
Uh,
fatigue?
Actually, this is a genetic condition, so mainly we will do for genetic counseling and genetic blood test for diagnosis purpose, and for the headache purpose, maybe patient with related with the anemia, and so we need to check that CBC, LES, CRP to see any inflammatory marker. We need to check that liver and renal function test if there are any electrolyte abnormalities, and also we need to do about the chest X-ray to see about that his condition of pneumothorax and any residual air or not. And also we need to do ECG and echocardiography to check his cardiac condition, ruled out that cardiovascular disease, valvular heart disease. And for headache, as there is a long time, last 2 months headache fatigueness, we can do one brain MRI to rule out any structural abnormality or not. Maybe it's affect over the muscle syndrome. Maybe there is a also it's can affect over the structure of the brain. So we need to rule out by MRI.
Okay, then how you are going to treat?
So in this case, actually, this patient, as we need some investigation and that MRI, chest X-ray, and cardiac echo and ECG, we need to do first, and we need to first for initially we can admit for like for the investigation purpose, and we can give some painkiller medication and analgesic to reduce his headache, and we need to check about the dehydration status. If we feel then the dehydration, we can give IV fluid, and also for we can involve the physiotherapist for the joint pain, and also occupational and social health worker we can involve, and according to the other complication, as it's a genetic disease, so only there is a symptomatic treatment. So with that non-pharmacological therapy supportive treatment, multidisciplinary, and also treatment according to the complication, like for eye complication, cardiac complication, complication, and rheumatological complication. We will assess and we will treat according to the complication.
Okay. Okay. Thank you. Well done.
Okay.
Okay, thank you. Thank you, Dr. Tanvir. Well done. We will hear Dr. Rhoda comment, then I will comment. You can start the comment.
Yes. Hello.
Yes.
Yes, we can
Yes.
hear you. Yes.
Okay. You did great. Just a few comments. Like this patient, actually, he told you like at the end that he knows that he have a Marfan syndrome, but no one explained to him. So and he had like a cardiac complication, maybe like aortic regurg or any aortic root dilatation. That is why he's taking a beta blocker. And he has this recurrent pneumothorax, and he's planned for surgery, maybe pleurodesis in the future. This will make the explanation for the concern and the management different. It will be more simpler, like to make a shortcut. For example, like this patient, he has a morning headache and fatigue. It goes with obstructive sleep apnea. And in this patient with Marfan syndrome, they have this obstructive sleep apnea because they have like a small jaw, crowded teeth, and laxity of their upper airway. That is why they may get a sleep apnea. And then the management and the explanation will be for the, I appreciate your concern, you have obstructive sleep apnea. Might be secondary to your Marfan syndrome. And the investigation will be the polysysmography. And the management will be like a lifestyle changes like oral device, CPAP, or even surgery. And regarding the respiratory complication, yes, the pneumothorax, as you say, the recurrent pneumothoraxis. Also, what else? Like they may have like scoliosis, kyphoscoliosis, bixus perinatum, exactantum. The thing is, they will cause a restrictive lung disease. Other respiratory complication, there is study like they have some patient with Marfan have emphysema. And the last thing, the obstructive sleep apnea. But otherwise, you did it great, Dr. Tanvir.
Okay, thank you, Dr. Huda, for your explanation. Actually, my first question is when you feel headache, snoring, night, so my diagnosis goes to directly to obstructive sleep apnea.
Yeah,
But
yeah.
when you say that low body weight, no increasing weight, no neck some circumference increasing, and also when I saw the picture, that time I just deviated from the sleep apnea. That's why my mistake. Thank you for pointing out.
Yeah, thank you, Dr. Tanvir. Well done, by the way. It's very difficult scenario and a very difficult link between Marfan and OSA, obstructive sleep apnea. First time to know this information.
Exactly,
Uh,
exactly.
Yeah, however, it's good to know with the practice rather than knowing in the exam. Because in the exam, yes, as Dr. Tanvir said, I never correlate the obstructive sleep apnea to his face and to his body weight, body mass index. Even the neck, even the tongue is not small. Suppose his tongue would be tall or long tongue, elastic one, but never I will think that his mouth cavity is small. That's why he's having subsleep apnea. But it's yes, with the arched palate, so you can expect any abnormality in his mouth and oral cavity by any form, either the soft or the hard palate or the mouth itself, the opening, the teeth. So this is more fun. Let me ask Dr. Ruda, what if I put mean to be as a complicate or as association mean to be marfan and pheochromocytoma and headache with hypertension or pheochromocytoma can be in this case?
May you repeat your question, Dr. Basim? I'm sorry.
Yes, meant to be in the form of
Mm.
pheochromocytoma and Marfan syndrome.
Yes, it could be like a
Pheochromocytoma,
Marfanoid feature. Yes.
yeah, marfanoid features with the pheochromocytoma, hypertension, and headache. I know it's rare, but the case also is a new case for me. That's why I put this as differential. Uh,
I
but
think
the
we can put
vital,
also like a homocystinuria, but again, is that there is less cardiac complication, and they mentioned like we have
yeah,
like a recurrent thromboembolism, and what else? They may have like a mental disability.
yeah, coarctation of aorta, is it there with the Marfan? Any
I,
along with the aortic regurg? Is it
I think
associated?
aortic regurg, mitral regurg, mitral valve prolapse, aortic root dilatation,
Yes,
and dissection.
but no coarctation. Yeah, because yeah, connective tissue disease. So
Yes.
suppose the tissue will be more elastic and the prolapse and the regurg are more valid in the case, not the stenosis, because the stenosis it's not something in the elastic or the elasticity of the valve. Okay, let's comment from the beginning. As a headache and fatigue case, started by onset course duration, Dr. Tanvir asked everything, the onset, the course duration, gradually 2 months, the timing more in the morning with snoring. But the scale, Dr. Tanvir, always remember the scale. Please, any pain or headache, offer the scale and offer painkiller in case the scale or the pain
I
score
I
more than
asked I
you
asked
ask.
about the score, yes, and about the painkiller. That are you stable to take give the
Yes, I know.
history or you
You
need
ask
any
about the
medication?
painkiller, but the
Yes,
painkiller killer. But you ask the score. I cannot remember the
yes, I
score.
asked him. He
She
said me
scale.
that she said me that 3 to 4. Yes, I asked.
Excellent. Sorry, I didn't hear that. Okay. Then you ask for the alarming sign, but also the nature of the headache. You can ask the nature of the headache. You might have subarachnoid hemorrhage as association with the connective tissue disease or the vessel or blood vessel elasticity, especially if acute onset headache. I put in the differential, but against
Actually,
my
there is a two
differential as
month
subarachnoid.
as said 2 month. That's why actually I'm not asking about the neck
Yes,
stiffness like that
excellent. Yeah,
because
yeah. But
stating it.
even you can ask the nature because you will know that it's more
Yes, as
correlated
nature,
to.
of course, I need to ask. Is
Yes,
that so
excellent. Yeah,
being dull or any stabbing? We need to ask, of course. Thank you, doctor.
agree with you. Okay, then the CNS screening as a headache and fatigue. Starting from the vision, there is some vision change, of course, due to the lens deformity or the dislocation of the lens. By the way, Marfan will be upward dislocation, but in the homocystinuria will be downward. This is the difference. Okay, the speech, the weakness, the sensation, all neurosurgery or neuro CNS system asked by Dr. Talbir for relevant system. Then the weight change and constitutional symptoms. You ask about only the weights. You can ask also about other. Remember weight and others together. The temperature and appetite. Just not in this case. I mean, in any case, because it might lead to think about serious condition like malignancy or other autoimmune disease. Okay, the cardiovascular, there is some racing in the heart, of course, related to the aortic regurg and chest pain, the chest symptoms, short of breath, the GI. Yeah, the most important here also, he asked about alarming signs of headache, like throwing up or feeling sick, and then the headache worse with the bending forward. This is important question to rule out alarming sign of headache and increase intracranial pressure for any headache. Just to show the examiner, even it's not in the case, but at least show the examiner that you ruled out the high intracranial pressure question or signs of intracranial pressure. So sneezing, more with the sneezing, more with the coughing, with bending forward, or throwing up, feeling sick. All these signs going with increased intracranial pressure. Better to ask to rule out the emergency of the case. The genitourinary changing the color or amount or frequency joint pain, and you found ankle swelling might be due to the elasticity of the joint. The bleeding and the skin rash, you can ask also about his skin elasticity. Did you notice your skin more elastic than your colleague or your friends? Because also it might be the skin and connective tissue disease. You ask about bleeding, it's a good question for Marfan also because maybe there is I don't know what's the relation between bleeding and Marfan. Maybe you suspect like subarachnoid as I guess
Yes,
subarachnoid
yes.
hemorrhage.
It's maybe
Yeah,
elasticity and organ. Maybe even there is a dissection, aortic dissection, and even any type of the
excellent.
dissection, any aneurysm can
Yeah.
develop.
Yes, yes, agree. Okay, then the family history, patient is adopted, so this is also going with the since once you see or you hear the patient is adopted, you will think there is some inherited or genetic or familial condition. The travel here is not that much important. The medical history, including the surgery, including the medication, there is painkiller, beta blocker also for the aorta. It might be aortic regurg, so he take beta blocker. And the pneumothorax, as Dr. Tanvir asked, for the surgery, pneumothorax is one of the indication for surgery, recurrent pneumothoraces. The job, the smoking, the alcohol, finish already. The examination, Marfan examination. Just show the examiner that you are looking for signs of Marfan. Starting by the hand, Rakendo, what's called, the long finger, I mean, Aricodactyly, what's
Araconodactyly.
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 Yeah, Araconodactyly. But I cannot repeat it again. It's long finger in a way. This is the same term. Long finger, and you can do the thumb test. Ask him to flex his thumb inside his palm, and you can notice the thumb is out of his palm, longer than the palm itself. This is one of the tests, and ask him to extend the thumb. It can touch the forearm. This is also the thumb test. For the elasticity, he can also do some strange movement for with the fingers, with the elbow, any joint, the shoulder. You can ask him, by the way, any history of dislocation in your joint, uh, any trauma, as Dr. Tanvir asked for trauma. But he's notifying that his joint being different than his friends, and he can tell you, yes, I can do some movement which is difficult for others. Okay, this is for the examination of the hand, and very important, the pulse and vital charts. We didn't ask the Tanvir, but the pulse specifically very important. The pulse as a
She
number.
already said pulse. She already said pulse, blood pressure, everything normal in the scenario.
Hmm, no, I didn't mean the
Al-
pulse as a number. The pulse as the volume. Aortic regurg mean,
Yes, yes, yes.
yeah,
Yes,
yeah,
collapsing pulse, high volume pulse.
collapsing
Yes, yes.
pulse.
Yes,
Excellent,
yes,
yes,
yes.
excellent. Yeah, this is important. Then you can ask also for the pulses in both arms because it might be it's a visual disease, so you might have some change in the pulse, change any delay from here to there, or delay from the radial to femoral, because you don't know what is the case. Maybe there is other complication or visual complication. Okay, this is for the hand, for the arm. Then the skin itself, you can touch his skin and you check his elasticity. But suppose his skin is not that elastic like Ehlers-Danlos syndrome. This patient more affecting the joint and blood vessels compared to Ehlers-Danlos. Yes. Then yeah, the face for the eye, as Dr. Tanvir did, all vision will be examined afro from acuity and the field, reflexes, and finally by fundoscopy. Uh, the slit lamp for the lens, I think also it can be examined, the lens itself, but Dr. Roda already skipped it. And the mouth is very important, high arched palate. You can check by yourself the jaw, any abnormality, the nose, any change in his facial features is very important to check. Then the neck for any elastic or a change of the shape of the neck, especially this patient is obstructive sleep apnea. You can ask him also to protrude his tongue out to check if the tongue is big, but I don't think the tongue will be big. The tongue will be long rather than being big. Okay, then the neck, the chest, very important the chest. Rule out pneumothorax by examination, and for the heart, for any valvular affection like aortic regurg in such case. Very important. The apex, displacement of the apex might be there due to aortic regurg and the murmur over the aorta in the sitting position on expiration or after holding the expiration. The abdomen for organomegaly quick exam. Then the ankle itself, as there is some change in the ankle swelling, I don't know, maybe something important, or I don't know if it's important or no, for Dr. Roda can tell us. Then we'll go to the differential. As Dr. Roda said, Marfan with obstructive sleep apnea due to small mouth opening. For me, I will put Marfan with pheochromocytoma, Minto B, and the last as a complication or association, you can put also coarctation of aorta with Marfan. I don't know if it can be or it can be as association or not, but the headache and some aortic change could be like our coarctation you can put in the definition. But you can say against that, no change in the blood pressure and the arms and leg, no aorto, no residual radiofemoral delay. Of course, you will offer it in the examination. Okay, thank you. Let's read the comments before moving to the next scenario. Dr. Roda, you can write your scenario, please. Sorry, Dr. Tanvir, you can write your scenario to Dr. Roda.
Okay.
The driving is important here. Yes, sure. I agree, 100%, because he has some also vision problem. All would ask this question together, Dr. Tanvir. They are smoking. Do you smoke? Do you drink alcohol? Do you drive? Along with the job. Aortic regurg. Most common association with Mafan, yes, agree. Aortic regurg. Ret Retigent, yeah, small jaw. Crowded teeth. Arched palate, yes. Why obsessive apnea suspect here? Dr. Abdullah is asking. Because of small jaw and small mouth opening. Actually, for me, this first time to know this case. So I don't think is it coming in the paces or did it come before anyone heard about it or Dr. Roda brought from a book. Laxity of tissue and partial obstruction. Yes. Dr. Roda, prepare yourself. Mrs. Mona, 60
All right.
years
Okay.
old with back pain. So sorry, Dr. Roda. Yeah, we have
Okay.
question
I
for you,
will take
Dr.
two
Roda.
minutes. All right.
Yeah, yeah.
2 minutes.
Please, the 2 minutes. Yeah, please 2 minutes before we going to the preparation. The case was basis wise. I mean, the previous
Mm,
diet or from book.
it's a full book.
Okay. Yeah, I
Yeah.
think that because it's very difficult to bring patient with Marfan suffered from obstructive apnea because his weight
Yeah.
is not that much.
Yeah,
Anyway, thank you for your effort.
welcome,
Appreciated always your effort, Dr. Goda. So
welcome.
take 2 minutes. Thank you. Look, take 2 minutes, then we'll start back.
Sure.
By the way, for any Marfan patient, there is screening or survey to check his aortic root diameter. Yes, Dr. Hassanin, you can. I'm not
As-
muting anyone.
Assalamu alaikum.
Alaikum salam. Yes, Dr. Suga.
Yes, how are you, Dr. Basim?
I'm fine.
Okay, so actually, the Marfan is a little, it's not common, but it's, yes, in Pakistan, they give a lot of cases, and in England, they also give a lot of cases with Marfan. So we have seen a lot of patients of Marfan over here. And you were right. When we see the patients, we just give a general look to our patients. And general look, we have to see the height of the patients if it's below the couch or not. Because many people who have the initial symptoms, they don't have long, elongated fingers, which is called arachnodactyly. And they don't just have but yes, they have a hypermobility of the joints. That is why their skin is a little bit elastic. The all connective tissue diseases who especially the Marfan and Ehlers-Danlos, they have hypermobility of the joints, and we have to do our skin elasticity of the test. Skin elasticity on hands, we will check the long elongated fingers, plus we will check the elasticity, plus and after that we will check the yes, the finger test. But it's the easy way to do that. If you just ask the persons to hold the hand like the wrist with thumb and the small finger, the just to take the fist, and if that is able to touch, and ask the patients to make a fist. And if the patient make a fist, if the thumb is going down below the fist, then it means the patient is having elongated fingers. Then after that we just move to the, after checking the pulse, which is, as you told, it is very important, then we go to the eyes. And we check the there is not strongly associations of obstructive sleep apnea, but there can be associations. Usually the more strong association is intracranial bleed. When we check the eyes, in eyes we see the bluishness of sclera. That is very common. That is the bluish discolorations, and it comes, you can visualize without fundoscope, you can visualize in the eyes as well. Patient can have a little sallow look. They seems look a little uh, they have elongated jaw, a little jaw elongated. And in fair people it's very prominent, but in a little dark people it's not that much prominent. So we just have to visualize that. Yes, the hallmark is uh, the jaw, when we open the mouth, high arch palate is the hallmark for that. And there are the spaces of crowned teeth, and the interdental spaces and crowned teeth, they are less likely, they comes not on regular basis. In heart, the aortic regurgitation is very common. And aortic regurgitations, and there can be visible pulsations on the neck when there will be aortic regurgitation. And there can be mitral valve prolapse as well. So if somebody knows the cardiology examinations, maybe they can easily pick that. But mitral valve prolapse, they give a just little small click, and the click that is difficult to pick if you don't have. But aortic regurgitation, which is a murmur of the early diastolic murmur, that is rumbling murmur sometimes, and it's very easily pick. It's you can catch if you do a little practice. Plus there will be visible pulsations. Chest deformity, there is a little deformities on the chest. There can be wide spaced nipple chest as well. And after that we can check the joint effusions as well. Organomegaly, it's very rare, but yes, there can be organomegaly, and always on the history ask for the back pain because people with Marfan present with back pain as well. Back pain due to dural ectasia, and that is why they just come with the back pain. So always ruled out, and then check the joints. And after checking the joints, if there is any effusions, always ask the rashes. Always check the feet because there can be the hands and plus the feet abnormalities will always be there, and there is a high risk for pneumothorax. And the person who are at the risk of pneumothorax, there is a high chances to developing a thromboembolic phenomena. So to rule out the thromboembolic phenomena, because people with Marfan, they can present with chest pain, they can present with back pain, and they can present with headache. So whenever the patient, especially the patients who are coming with some genetic cause, who are presenting with genetic abnormality, which is prominently we can see, we just need to focus more on the primary presenting complaint. We need to sort out that complaint, and we need to tell the cause of that complaint, diagnose the complaint, and then tell the complication of that complaint. So if the in regard of the syndromic or non-syndromic, so whenever the patient with syndrome, always rule out the primary complaint first. So uh, after that, yes, genetic testing is diagnostics. But if the patient comes with intra headache and that is very severe, and you rule out that it intracranial bleed, then the first thing we will do is CT scan. After that, we will guide the patient to go for the genetic testings. That's all I at this moment I want to add.
Thank you, Dr. Sugar. Yes,
Yeah.
you remind me it's pivotal for the it's what's called the sternum abnormality, craniatum and
Yes,
excavatum. Pictus,
yes,
yeah, Pictus.
there can
It's
be chest
yeah,
yes, the prominent
yes,
chest
this is one.
abnormalities, but
Yeah,
chest abnormalities, and there can be the chest abnormalities in young patients. It develops very late. I saw the boys who are teenagers and they having the Marfan features, and yes, with Marfan, aortic regurgitation is strongly associated, but VSD is all VSD can be always there. VSD, I saw Marfan with VSD, a lot of cases with VSD.
yes, yeah, I agree. And don't forget as well the scars for pneumothorax, either surgery
Yes,
or chest
yes,
tube. Yeah, it's very important. For
yes,
differential, Dr. Tanvir put the overuse headache, medication overuse headache. I think it's more wise to ask about the painkiller duration and frequency to put it as a differential. Yes, it's good differential if you put it if you analyze it well, especially if the patient take it for more than 15 days in 3 consecutive months. So I can put over indication overuse headache. It's very valuable.
I asked about that. Are you taking frequently medication or painkiller? She denied actually. So for ruled out analgesic induced headache, but she denied.
Yeah.
But we
No, I
need to
think
ask.
she said she's taking painkiller. I think so, but
No,
she
no, she
denied
said that
maybe
occasionally, yes, not
occasionally.
regularly.
Okay, yeah, yeah. If
Supposed to be,
regularly,
it will be
that's
like
right.
more than 3 months.
Yeah, yeah. If like that, yes, you can
yes.
put it as a different. Yeah.
And Dr. Tanveer, we can also put the tension headache as a differential in every patient's tension headache, especially if the patient is waking up at night and the patient
Yes,
is
yes,
having, we have to explore the job, we have to explore the stress because the patient is syndromic. Every syndromic
yes,
or
yes.
every person who has a genetic condition, he will be always worried and his anxiety level will be always high. So we can also put the tension headache as a differential if they give the symptoms to explore more.
Yes, I agree,
A-
especially if there is stress in the life. But I
Yes,
can't
Actually,
put it, or I can say again, is that the nature of the headache is not band-like. So if not band-like, I will say that it's again it's the attention headache, the nature of the headache. but still I can put it if the patient having some stressful condition in his life. Yeah, I agree. Yes, Dr. Tanvir.
Actually, like if there is a somebody have chronic headache and younger person with there is a no red flag, we should first evaluate about the tension, migraine, and cluster headache because all are mostly recurrently coming intermittent headache and mostly it's not present with the red flag except sometimes about the migraine. Migraine sometimes present with there is a hemiplegia, with there is a visual problem aura. So in that case, actually, yes, your point right. That's why initially I asked Dr. Huda that are you any type of the stress in your job or in your family life? Because this is very important. Maybe she cannot sleep properly all the time under the stress in the job or social or familiar life. So we need to rule out about that any stressful condition or not.
Yes, yes, agree. But we can't put migraine without aura. We can't put cluster without eye tearing. Don't put it in the differential. But you can consider it to analyze and to rule it out. Yes, I agree to rule it out, but will not be in the differential. I agree. Yes. Thank you, Dr. Tanvir. Let's start the second case. Dr. Roda, are you ready?
Yes.
Okay, I will share the timer. Yeah, you can see the timer now.
Yes.
Here you go.
Yes. Hello there. I'm Dr. Zain, one of the doctor covering the service today. Am I talking to Miss Mona, 60-year-old?
Yes, doctor.
We are here to discuss issue related to your health. After that, I will examine you, okay?
It's okay, doctor.
So tell me what the problem.
Doctor, actually, I have back pain for the last 6 months, and now very difficult to maintain my daily activity, sometimes
Mm.
movement. So I'm worried actually what happened with me.
I'm really sorry for that. We are trying to figure out what the problem. Do you have the pain now? Do you want any painkiller?
No, it's okay. I already take painkiller.
Okay. And before these 6 months, do you have you got this pain?
Actually, previously it's little, but now last 6 months it's more.
Okay. And is it where in your back? Is it on your neck, middle back, or at the lower back?
Actually, mainly in my middle back, but sometimes also lower back.
Mainly in where, Miss Mona?
Mainly in my middle back, but
Middle back.
sometimes also I feel at the lower back.
No, okay. Okay. And have you, when you got this pain, how would you score it from 1 to 10 for the severity?
It's like 5 to 6.
Okay. And is there anything like improve it, like rest or taking a painkiller?
I feel little improvement, not too much with the painkiller rest.
Okay. Does it increase what increase it? Like exercise?
Uh, Actually, I feel like when I'm moving, I feel it's increased little more.
With exercise it and
Actually, I'm
in,
already not too much exercising, but sometimes if more movement, that time it can intervene.
And what about stiffness? Do you have any stiffness?
Yes, sometimes I feel mild stiffness in the back.
Is it mainly in the morning?
No, it's not related with time.
No, not related with time. Okay. And so tell me, have you got any trauma to your back?
No,
Mm.
recently I don't get trauma.
Recently? Have you got in the past?
Yes, sometimes I get sometimes fall down like that. I feel little trauma in my leg, hand sometimes,
Have you got
but
any
not
kind
in the
of
back.
fracture?
Yes, one time I found there is a small fracture in my toe. I went to
Mm.
doctor, doctor gave plaster.
Mhm. Oh, okay, okay. Then I would like to ask you, do you have a problem controlling your bowel and water wall?
No, it's okay.
Mhm. Do you have any weakness anywhere in your body, including your foot?
I feel actually general tiredness, weakness.
All right. And do you have any pins and needles in your lower limb and other areas?
No, I don't see.
Okay. And then you told me like you feel general weakness. Is it all the day or in a specific time?
It's all the day coming, going, on off, not a specific time.
Yeah. Do you mean exactly by weakness, like tenderness in your muscles, or like you have no energy?
Yes, I feel there is a tenderness in my muscle, in my joints, like that.
Mhm. Mhm. Do you have like a problem with climbing the stairs or combing your hair?
Combing here, no problem, but climbing a stair, yes, I feel little pain in my back while climbing.
Okay. Do you have any pain at your joint?
Sorry, what?
Do you have a joint pain?
Yes, yes, doctor, I feel my pain in my hand also, back pain
Pain
and
in
also my hand.
your hand. Where exactly in your hand?
It's mainly in my hand, over the finger, and over that hand area, below the
Where?
wrist,
Sorry,
like that. In the finger area and hand area.
in the finger and hand area. Does this pain like started in your wrist and go to your finger, or started in your finger and go? What the nature?
No, in the nature is here, only that local pain, not
Local
going
pain in the
anywhere.
finger and
Yes,
hand.
yes,
Uh-huh.
yes.
Do you have any change in the color of your finger when exposed to cold?
No, no, I don't see.
Do you have any joint swelling?
Yes, sometimes I feel there is a swelling in my hand.
All right. Is it in both hands?
Yes, my both hands.
All right. Do you have any stiffness in the morning for the hand?
Yes, sometimes I feel the stiffness.
Do you have any past medical history of a disease called rheumatoid arthritis?
I don't know that. I went sometimes to doctor. Doctor gave me painkiller, but he did not do any test. He said it's maybe normal pain, like that.
Mhm. And apart from this, do you have any past medical history with apart from this joint pain and this
Yes,
fracture?
doctor.
Mhm.
Yes,
Any
doctor. I have problem with thyroid.
with thyroid? Is it
Yes.
like active or low?
No, it's hyperactive. I take
And
some medication.
mhm. Are you compliant with your medication?
Actually, I am not taking regularly. It's really.
Right, all right. And have you had any kind of surgery?
No idea. Don't go for surgery.
Back to your thyroid medication. Why you are not taking regularly?
Actually, sometimes I feel sore throat. Sometimes I'm thinking that tired. I'm feeling. And sometimes
Mm.
actually I'm forgetting. That's why I'm not taking regularly.
It's all right. Do you have allergy to any medication?
No, no.
Okay. Do you have any change in your weight?
Weight actually I have no body weight actually from the beginning.
And is it intentional?
No,
Or
actually, like yes, I feel little poor appetite like that.
Mhm. And
I'm not taking actually properly food also.
do you do how much you lose weight if you lost weight, like and over how long?
No, actually, my weight is low from the beginning. It's a long time. Like my
Mm,
BMI is like 80. It's a long time.
Okay. All right. And do you have any problem with your temperature?
No,
Any lump or bump?
no,
Any issues with your mood?
no, it's okay.
Are you in a specific kind of diet, like a vegetarian or something?
No specific kind, but I'm not actually feeling too much interest my food about my food.
But what you say?
I'm not feeling too much interest about the food. I'm not taking too much enough food.
You have a decrease in your appetite. Okay. And then what? Anything with your bowel motion?
No, bowel motion is okay.
Any yellow discoloration of your eye
No,
or pallor?
no.
Okay. Any heart racing,
Yes, sometimes I feel heart racing.
chest pain,
No,
dizziness?
no,
Any problem with your water work?
that's okay.
Any gravels like?
No, I don't switch.
And do you smoke?
Yes, doctor, I'm a smoker.
How much and over how long?
I'm taking maybe 20 cigarettes per day for last 10 years.
Actually, smoking is hazardous for our health. I am advising you to stop it, all right?
It's okay, doctor.
Do you drink much alcohol?
I'm sorry. Yes, actually, like weekend time, I'm taking more.
How much? What you say?
It's something uncontrolled. I am not counting, but I'm taking more in my off or holiday.
No, alcohol could be also related to health condition, and we will sit with a dietitian and we will refer you to the specific area to help you try to cut it, okay?
Okay, I'll try.
Okay, and then I will examine you. During examining you, I will ask you further question if you don't mind, okay?
Okay, doctor.
Okay, then regarding the vitals,
Vital is 140 over 90, RBS 8, BMI
Mhm.
18.
And bulk rate,
Absolute normal, 50 beat per minute regular.
and the rest, temperature, all of it normal.
No, temperature normal.
Okay. And then I will go for the patient looks cachectic, anxious, any like
Yes,
bulging in the
little
eye.
low BMI, little low BMI. It looks little tired looking.
Okay, then I will go for the hands, any like for the sweating, any fine tremor,
No
any joint.
sweating,
Yeah,
no sweating, no fine tremor, but metacarpophalangeal joint while swelling.
metacarpopharyngeal joint swelling. Is it hot?
Symmetrical, symmetrical, not hot,
Not hot. Any effusion?
not efficient.
Then any deformity?
Looks like slight deformed, not too much, slightly.
I will offer to do a hand function. Do you think that your hand function affected, Miss Mona?
It's slightly affected sometimes, not always.
I will ask her to do a hand like a hand grip and pincer sign and like flexion of her wrist and so on. And
Yes,
then
he
I
can pick the coin and unbuttoning, but feel gripping is little weak.
wait,
Gripping power little weak.
any tenderness in your when I will like a tapping on her wrist, any numbness and tenderness in the high in the median nerve area, in the
No,
thenar area.
carpal tunnel syndrome negative.
Negative. Then I will check the pulse
Tunnel test
regular or
negative.
not.
Yes, yes,
Okay.
regular.
Regular and check for collapsing pulse.
No, it's okay.
And I will
No
check for
collapsing.
the proximal myopathy.
Yes, it's okay.
Okay. Then I will go for the face. Any exophthalmos.
It's slightly exophthalmos.
I will check for the lid lag.
Lid
Also,
retraction. Yes, lid
okay.
retraction. Okay.
All right. She's no case of a hyperthyroidism. Then I will check for the neck.
Slightly
For
swelling. Light swelling.
okay. Swallowing. Do you have any difficulty of swallowing, Miss Mona,
No, it's okay.
or a change in your voice?
No, it's okay.
I will percuss over the chest for retrosternal extension.
No retrosternal extension.
All right, and then what else? I will do cardiovascular examination. Any added sound or murmur?
No murmur added sound, but heart sound is little loud.
First one or both?
Second heart sound.
Second heart sound. Any palpable B2, raise
No, no
JVP?
palpable. No palpable P2, no rest JVP.
Okay.
2 minutes
Then
remaining.
I will hold on. Hold on. Okay. Then tell me, what's your concern? I will offer lower limb CNS examination. What's your concern?
Okay, doctor, actually, what happened with me? Why back pain happened?
Mm, mm. I do really appreciate your concern, Miss Mona. After assessing you, I think you have got what is called as osteoporosis. Don't bother yourself with the term. It's when there is a thinning in your bone. It might be related to many things, actually. It could be related to you, like a problem in our defense mechanism that we call it a rheumatoid. We will investigate for you. And it could be related to your high alcohol intake, could be related to smoking, and it could be related to your uncontrolled thyroid problem. What we need to do now, we are going to admit you. We will run some blood tests and imaging, and including our whole team, including the bone doctor, joint doctor, gland doctor, and specialized nurse. Meanwhile, I want to ask you, do you have a family history of thinning of the bone or fracture?
Yes, doctor, as I said, I have history of a fracture in my foot before.
All right. And I forgot also to examine the back. I will examine the back for any tenderness at the lower back, any scars.
No scar, but tenderness in the back,
Where exactly?
in the lower back.
Lower back. All right.
Yes, in the sacral, bilateral sacral area.
Or bilateral. Okay. And I will offer also to examine the groin and rectal tone. So do you have other concern?
Doctor, I want to know that is it curable?
I appreciate your concern, Ms. Mona. This condition, yes, it's curable. It's curable when we treat the cause and give you the treatment for it. Yeah, it could be curable and could be manageable. Do you have any other concern?
No, it's okay, doctor. Thank you.
Welcome.
Okay, well done, Dr. Roda. Thank you. Let's go to exam time.
Okay, so please
Start,
present
please.
your case.
Okay, this 60-year-old Miss Mona complaining of a lower back pain for the last 6 months that started gradual and increasing in its severity. And then this back pain also associated with a recent history of a joint pain in her both hands, associated with the stiffness, and mainly in her metacarpopharyngeal joint, bilateral. And also she gave a history of racing of her heart, and also uncontrolled hyperthyroidism and compliant with her medication, maybe due to the side effect. She also gave a family history of thinning of the bone. On examination, there is like vitals are normal, apart from the blood pressure is upper limit 140/90. And there is like a swelling in the metacarpopharyngeal joint and tenderness, no fusion, no hotness. Also in examination, I think she has like hyperthyroidism, might be Graves' disease or something. Also, there is a tenderness in her lower back. Yeah, she has a decreased appetite. I forgot this. Might be related to her vasculitic issue or something. Yes.
Okay, so what is your differential diagnosis here?
This is a kind of a mechanical type of back pain. It could be, first of all, it could be osteoporosis for differential. In this case, it could be related to her connective tissue disease or a mixed connective tissue disease we need to investigate. It could be related to her hyperthyroidism, uncontrolled. It could be related to something related to the diet. It could be related to smoking. It could be inherited because of her family. It could be related to her high alcohol intake.
What are other differential here? except
For
osteoporosis.
in state of osteoporosis.
Yes,
Yeah,
what are the other?
it could be like a mix that we need to search for the primaries, especially in her age, for example, in her breast, lung. We need to investigate further. Other differential, it could be like trauma, but they denied any kind of trauma. It could be like a bursitis or abscess, but denied any history of a high fever or any source of infection. Yeah, it could be like a muscle strain.
Okay.
Mm.
So how we will investigate this case?
All right. I will investigate this case apart from the basic lab, including full blood count, looking for any anemia of chronic disease, bone profile, calcium, phosphorus, ALB, important in osteoporosis and osteomalacia. What else? Inflammatory marker. And then what else? I will do MRI and DEXA scan for the back. I will check her thyroid function again. Check for her vitamin D level.
Okay, so
Yeah.
how we'll treat this
Yeah.
case?
How what?
How we'll treat this case?
Okay, apart from the base, apart from like non-pharmacological and pharmacological and surgical. Non-pharmacological, educate her about her disease, counseling, refer her to a multidisciplinary team, including the a rheumatologist, orthopedic, dietitian, physiotherapist, occupational therapist, and others. Avoid smoking, moderate her alcohol intake, yeah, and by medication, we will check her vitamin D level, calcium, if she need like any kind of a supplement. We can, if there is, if she's tend to be like osteoporosis, we will give her like bisphosphonate with the instruction of the bisphosphonate. Yeah, we'll give her a painkiller, of course. And yes, this how
What
I'm
are the
gonna
other
do this.
options? What are the other options specific for osteoporosis except
Okay,
bisphosphonate?
okay. Apart from the bisphosphonate, there is could be like a hormone replacement therapy. Others, it could be like a parathyroid hormone pulse therapy. I think, I don't know if calcitonin, I think so. This is the thing that I
Okay,
know.
okay, doctor, thank you.
Welcome.
Yeah, great discussion, Dr. Tanzir and Dr. Roda. Let's hear the comment from Dr. Tanzir, then
Okay, I
we
just
can start.
give some comment. Dr. Huda did nice, taking good history, good examination. Just few point and few examination list. Actually,
Okay.
this lady is 60 years old, Mrs. Mona, and as she repeatedly told that her BMI is low, looks weak, and poor appetite. So,
Yeah.
in case of the osteoporosis, this is the very important thing about the lifestyle. So what
Yeah.
about maybe need to ask that are you active? What's your profession or what you do? Because mostly there are homebounded, old age, poor activities, and
Mm.
poor diet. So these are all the lifestyle and dietary habit very
Yeah.
important for the osteoporosis.
Yeah.
Like for the osteoporosis improvement, need proper diet, especially calcium and vitamin D containing diet, need
Yeah.
something muscle related exercise and
Yeah.
stretching, muscle bearing exercise, weight
Yeah.
bearing exercise. So this is very important. So we need
Mm.
to ask about the lifestyle of the patient, about the diet, and about the sun exposure. This is very
Yeah.
important. Even when you are treating as a non-pharmacological, that time you have to mention also need proper diet containing calcium, vitamin D, muscle stretching exercise, and also weight bearing exercise. and balanced diet. We need to rule out during taking history and also as a treatment purpose. Okay, and it's mostly happen in the elderly ladies. Male person are little less prone to develop the osteoporosis. So if this lady is 60 years and also there is a history of the fracture fall down, so she is under the case of supposed to be osteoporosis fracture happen and she need
Yeah.
actually take the scan for diagnosis. So if anything if you I mean, when you can take the diagnosis, when you understand the diagnosis, better to tell something specific, something like you mentioned DEXA at the last time. But in case of that case, you should tell DEXA initially, like
Yeah.
basic blood test, CBC, SSCRP, calcium, vitamin D, bone profile, vitamin B12. Along with that, when you are going for imaging on specific test, initially you have to tell yes, X-ray we can do and also DEXA scan. And later, if you want, later you can add MRI. If you suspect need MRI, that case,
Yeah.
because MRI actually not need everywhere, but if you think you can add later. And
So,
also like that here regarding that some history, some things very important osteoporosis cases because osteoporosis usually they have something lifestyle
mm,
problem, something about the dietary, something about
yeah.
the history of the smoking and alcohol. They have
Okay.
something connective tissue disorder. They have
Correct.
something organ failure, renal or liver failure. They
Yeah.
are a smoker, alcoholic, and the very
Yes, I
important
also
thing you
understand.
forget to ask about the menopause. Early menopause is a very important, like as a social, when you're taking the social history, and also do you have any past medical long-standing disease? Are you taking any medication? Or what about your family members? They have similar type of the disease or any other disease. Are you taking any recreational drug? Something.
Mm,
And
yeah.
regarding that, smoking alcohol at that time, who is supporting in your family?
Correct.
And also they have similar type of the disease like fracture. And if you don't mind, can I ask you what about your last period? So because there is supposed to be early menopause, it's happened. So diet, lifestyle, menopause, smoking, alcohol, and sun exposure, and organ failure, connective tissue disorder is very important. And regarding the
Okay.
DEXA scan, already mentioned to you, DEXA scan. And that other investigation, yes, you can do calcium phosphate, ALP like that, but mostly these are coming as a normal. So if the
Yeah.
DEXA scan is more than minus 2.5, it's a case of the osteoporosis. We need lifestyle and also medication management. But if between the minus 1 to 2.5, that time only lifestyle measurement mainly need, and that is
What you
diagnosed
said
as a
again, if it is between what?
yeah, it's a DEXA score, T score. In the DEXA scan, T score. Just only for knowledge. DEXA
Mm,
scan T score is more than minus 2.5. It's a diagnosed case of the osteoporosis. We need
mm,
lifestyle and drug management. If
mm,
osteopenia, like between the minus 1 to minus
mm.
2.5 is the osteopenia case, we need
Only
mainly
lifestyle.
lifestyle. And
Okay.
another thing is, if it's more than 75 years age, that time
Mm,
don't need to have the DEXA scan. That is the clinical diagnosis, and you
yes.
can start even this postmortem. But if below the 70 years old and repeated fracture, family
Mm,
history, and taking long time steroid, okay,
mm.
so that case you need to rule out by doing DEXA scan. And
Yeah.
regarding
And
the management,
doctor, I'm sorry for
yes,
interrupting you. I'm sorry. If
sure,
it is more than 75 with a recurrent
yes, it's a
fracture,
clinical.
no need to do like a DEXA and give her the bisphosphonate.
No, no. There no need of DEXA. 75, more than 75, it's a clinical diagnosis. There you don't need to do a DEXA. DEXA
Yeah,
you
and
will
it's
do
very
like 60 to
important.
70 years. Yes,
Yeah, and you are right that we need to ask about
yes,
steroid as a medication
yes,
also.
yes. Because
Yeah.
if there is a risk, you need to ask about the risk factor. This is very important. Even heparin, if patient taking long time heparin, this is
Yeah,
another
yeah,
factor. So
yes.
management is the lifestyle and pharmacological.
Mm,
Pharmacological, yes, bisphosphonate is the first line. If alendronate unable to take, so etidronate, residronate, and alendronate, they have some instruction like 30 minutes you need to take sitting position in empty
yeah,
stomach, like that. And other like that, some hormone replacement therapy and
mm,
raloxifene. But hormone replacement therapy, if there is a chance of the like hyper coagulation state. So we should avoid beta hormone replacement therapy. Even it can cause a more chance of the breast carcinoma. So
Yeah.
better in that case we should avoid. And raloxifene is good. It will be estrogen modulator. It will reduce the breast carcinoma
Mhm.
chance. And also we can give calcium, vitamin D supplementation. We can give teriparatide like parathyroid like hormone. We can give yearly 2 times subcutaneous denosumab, which is
Mhm.
a rank ligand inhibitor. And also, in case of the male, if it's a feature of the hypogonadism, we can give even testosterone for male person cases. And also, we need to rule out that chance of the fracture by the fracture score, 10 years, 10 years calculation of the fracture. We can calculate because osteoporosis, there's a more chance of the fracture. We need to even sometimes hip protector, social support, and more careful should be about that patient protection. Otherwise, even vertical fracture, hip fracture can happen. So this is our also target to reduce the chance of the fracture by calculating the fracture score. So these are all of my comments.
Mhm.
Thank you.
Thank you.
If anybody want to add, can add.
Thank you.
Yeah, thank you, Dr. Anvir. You will cover all the topic actually, the osteoporosis, and well done, Dr. Roda. You reach diagnosis. And always, I just take this advice. Whenever you put osteoporosis in differential, put with it osteomalacia, because both of them are similar. You can put osteoporosis with osteomalacia, you can put
Yeah.
osteomalacia with osteoporosis. Yes, always remember one, because it might be presented in the same presentation like back pain, lower back pain, I mean, along with the similarity of deficiency in the vitamin D. However, no vitamin D deficiency in the osteoporosis, but we are giving uh, every menopausal female vitamin D and calcium as a protective measure for osteoporosis, even the normal level of them. So it's crucial in postmenopausal female to take vitamin D along with calcium. And in osteomalacia, don't forget the sun exposure, along with also replacement of vitamin D and calcium. So my comment for you from the start, back pain started 6 months ago, onset course duration, the scale, the painkiller improved the previous attack, yes, the site, exactly, and where it goes. This is the only question, the radiation. Is it goes up, going down, or goes, it doesn't go anywhere? This is the only missing question. And for the increasing and the decreasing, I advise you again to ask by words related to the movement. Because for myself, I couldn't know it. Is it worse or improve? You said increasing and decreasing. So he might tell you it's increasing, then you can hear it increasing. So better to ask where worse with movement or worse with movement or the rest. If worse with the movement, this is mechanical. If worse with the rest, this is inflammatory. Okay, better to ask worse or improve. Improve with the movement will be inflammatory. Improve with the rest will be the mechanical. Okay, so you got that this is mechanical one. There is stiffness. The timing is important also to ask because also if the early morning will be like inflammatory one, but for the other day it will be mechanical. Any history of trauma? Excellent question also. This is for the analysis, but you keep still analyzing the pain and the alarming sign in this patient very important because if you have severe pain, increase of the intensity of the pain, there is weakness, there is loss of control of the bowel or pins and needles. You suspect the fracture of the osteoporotic vertebrae, and this is emergency case. So you should ask about the alarming sign in this patient. The same as for the headache, alarming sign of headache. So alarming sign of headache, alarming sign for back pain, just to know if there is any neurosurgical intervention due to nerve compression, either due to fracture or compression or prolapse, whatever the reason for the intervention. Then our analysis of CNS for the endocrine, there is affection of the endocrine system. But I don't know why you missed the question for the weather. You have now signs of hyperthyroidism. Ask the question for to show the examiner that you are knowing that there is affection of the thyroid. What you prefer as a weather, the
You
cold
know,
or the
because he said I'm hyperthyroidism, so I neglected it.
no, yeah, even, but you will know from this question if the patient is controlled or no. Because
Okay.
if, yeah,
All right.
hyperthyroid, yes, hyperthyroid and taking management compliant, he will tell you,
You
I'm
are
good
right.
now.
Yeah.
Yeah, yeah. So better to ask. Also, at the system review, if you take it from head to toe, system by system, you will catch the endocrine and you can ask in between the CNS and the chest because the thyroid in the neck. I'm always asking one question only. It can give you a clue for the thyroid state. Do you prefer any weather?
Right.
That's it.
Right.
Don't ask more. Okay, thank you. Then the GI and the loose motion or any change of the bowel habits, the genitourinary, the joint system, you ask for the hand and the finger. Uh, then you ask also for Raynaud, you suspect something in autoimmune, but I think this is not autoimmune. It's related to the thyroid state or the thyroid disease. Muscle pain, you ask also. The skin rash you miss and the female periods. In this patient, one question only for the female period, for the female history. The period only. You will not ask more than period because menopause, as Dr. Tanvir said, menopause itself exaggerate or it can uh, affect and it can accelerate the process of osteoporosis. So the period also is protected against osteoporosis because of estrogen. So you can ask this question specifically in this case. The family history, the travel history, the medical history, the thyroid state was affected, a history of thyroid disease, not compliant to medication, the surgery, the allergy. Then he addressed that he has some sore throat. You can also reassure him and ask why. You can also advise him immediately. You didn't give him advice about thyroid. By the way, thyroid as hyperthyroidism, one of the underlying cause of his osteoporosis. Hyperthyroidism is one of the causes of accelerating the process of osteoporosis. So I guess you can advise him to control and to take his thyroid medication, and you give him some red flag about the side effect for the future. Okay, and the importance of the medication. The constitutional symptoms you ask all: appetite, the sweating, the diet, and the question. Very, I like the question for the diet. What's your diet? Are you taking a balanced diet? This question for osteomalacia and for other vitamin deficiency, but mainly vitamin D. But you can add to the diet exposure to the sun, especially the Muslim females because of hijab. Sometimes they bring the case like this Muslim patient wearing hijab, so she's not exposing to the sun adequately, then the osteomalacia happen. Okay, then the smoking, very wise to ask about smoking and alcohol. All of them will also they are risk for osteoporosis. The driving, no need here. The job, yes, you can also ask for the job and need if need support. Yes, some exposure, yes, of course, for osteomalacia. The examination was target. You asked, but you missed the complaint. I agree to start by the hand, then the face, then the chest, then the abdomen. Me also doing that. But always remember while starting the examination, the complaint. I'm reminding myself as well because I'm always missing the main complaint. But whenever you start from the hand, remind yourself that you have some system or the complaint you must examine. You missed it here in this patient, but at the end you remember which is the back. Start as you do. hand, then face, then the neck for the thyroid. Examine full examination for the thyroid. And if you want quick for the chest and the heart, and go direct to the back. Don't miss the back because it will be against you. You didn't examine his back, and very important. And be gentle while examining the back. Maybe the patient is having osteoporosis, and the bone is already fragile. Don't be aggressive while examining. Don't be aggressive with the movement. Be gentle, and if there is pain, avoid the examination until the examiner, can I proceed, or he will tell you skip if there is some pain. Okay, so the differential for this patient, as Dr. Roda said, osteoporosis on the top, then osteomalacia, then as a mechanical cause of back pain, I can put disc prolapse or spinal stenosis. This is for me. I don't know if Dr. Tanvir will put another differential, but as a
Also,
mechanical,
metastasis
yes.
or multiple myeloma.
Okay, yeah, accept, agree. If there is constitutional, as in this patient, yes, this patient is having some constitutional symptoms, so you can put it. But multiple myeloma as should be their anemia and other
Yeah.
crab manifestation, crab
Or
for the multiple myeloma, yes. But let's okay, you can put if there is positive sinister signs or constitutional symptoms. I think Dr. Tanvir covered the topic of osteoporosis from A to Z, and the management plan as pharmacological or vitamin D and calcium is not according to the result. No, it's mandatory any female postmenopausal to start here on vitamin D and calcium. This is not as option. This is a mandatory treatment. Then you will talk about the option for osteoporosis like bisphosphonates, denosumab, hormonal replacement therapy in order in this order. You will not give this before this because whenever you go in the steps, the more the complication and the side effects. So starting by bisphosphonate and also bisphosphonate, you will start in a stepwise manner, including alendronate, and there is also IV formula. So you will start by oral, then IV, then denosumab, then hormonal replacement therapy in the last. The investigation, as Dr. Roda said, the DEXA scan, and Dr. Tabir also mentioned the score of DEXA from minus 1.5 to 2.5 to minus 2.5. This is osteopenia. Lower than minus 0.25, 2.5. This is osteoporosis. If there is history of any fracture, immediately you will start the management. This is another indication to start the osteoporosis pharmacological management. Any history of fracture, mandatory to start here on the medication. Plus, of course, the DEXA score. I think we cover all the topic of osteoporosis. You can also give some red flag about if the back pain, if you feel the back pain worse or sudden uh, severe pain, don't hesitate to call us or to come the emergency. Why? It might be fracture, and the fracture itself one of the emergency neurosurgical intervention or orthopedic according to the level of the vertebral fracture. Okay, I hope we covered the topic well. Let's read that. Sun exposure, job related, smoking, alcohol. Yes, does she take vitamin D? Excellent. Back pain always roll out fear, roll out pain is mechanical or inflammatory. Yes. Oscillation is second differential. Agree. Need liver and renal palpation as it may related to chronic liver disease. Yes. Estrogen. Estrogen. What's called metabolism? Yes. Estrogen metabolism. And chronic kidney disease, yes, of course, the vitamins will be related, activation of vitamin D in the kidney. I think we cover the topic. Any comment, any question? By the way, if you do liver and kidney examination, you will keep it after the back pain, or sorry, after the back examination. I will not do it liver and organomegaly and the abdominal full abdominal examination before doing the back examination. And the back examination will not take long. Like any joint, look, feel, move. Look for any scar, any deformity, any redness. Feel, you will feel the temperature to rule out, for example, discitis or septic arthritis or Box disease or whatever, any lesion, any collection, you will feel the temperature and you will ask the patient to move forward, backward, passively, and you can also uh, try to compress over the bone if no pain. But if there is pain, don't touch it. Okay, this is the back pain in brief. Oh, sorry, the back examination in brief. I don't think more steps will be needed.
Yes.
Liver, yes.
Can I add something, Dr. Basim?
Yeah, sure, Dr. Suga, yes.
Yes. Okay, so during the back pain, yes, you are right. We will inspect it. We will check the expansion of the back. We will feel it. And we will always ask the patients to, if there is no tenderness, if just the patient is having just back pain and we are not sure, then we always at the end, after doing the extension flexion of the neck joints, just to we will give the command to the patients to move the neck to the left side, to the right side, look up and look down. Then we will ask the patients to bend forward to touch the knees. If that patient can be done, then we will check all the movements, and after that, every time, and the end of the examinations, offer the gait of the patient is very important at the end of examinations in any back pain.
Yes, I agree with you. If there is a fiction of the back, like conus medullaris or the conus medullaris and what the other differential for conus medullaris? I forget the name. Anyway, I mean the affection of the nerve. So the gait might be affected, but I think also the time will not be enough to check for the gait. You have examined the palm, the hand, the pulse, then the neck for the thyroid, then the back. Then if you want to examine the abdomen and the other joint like the tendon affected and the knees, I think we'll not have time to ask
Yes.
him to
No,
walk.
no,
Yeah, but
no, Dr. Basil, we won't ask them. We will just offer them. We will offer at the end of
okay, yes,
examination
yes, yes.
that I want
Agree,
to
agree.
see
Yeah,
the
yeah,
gait of the patient.
yeah, yeah. I agree. Okay, okay. Thank you, Dr. Suga. I encourage all of
Thank you
you,
so much.
please. Yeah,
These
thank
were
you,
very
Dr.
good
Suga.
cases today. Yes.
Yeah,
And these
yes,
are the
always,
exam
Dr.
cases.
Yeah, always Dr. Tanvir and Dr. Huda bringing strange and new cases, but it helped us. And I'm always also encouraging, as Dr. Suga did, just share us with you, with us, sorry, share with us your information for two reasons. To take the confidence to talk, this is first. Second thing, when you say the information, you will be more confident with it and like refreshing yourself and refreshing us. It's a matter of being confident to the examiner. So I encourage all of you, don't be only listener. I I am free to listen to all of you, to take the confidence to talk and to be in the situation of not the exam, but at least near or pre the exam. Thank you, Dr. Tsuga, for your
Thank
comments.
you, Dr. Basim. It's
Yeah.
really helpful. Honestly, it's very helpful
Yes,
because
sure.
this is an exam just to talk and practice to talk. If we are
Excellent.
not able to talk, whether we study so hard, whether we do examinations, we do everything, but if we can't talk, then we are just failure. So this is a very good
Perfect.
platform you provided. We can talk
Yes,
to any time,
excellent.
and thank you so much. We can share
Yes,
and discuss the
yes,
things.
100% agree. In the exam, you will not think to talk. You will talk without thinking. The same as Dr. Sogad do and Dr. Tanvir, Dr. Roda, anyone practicing with us, he will be in the same situation in the exam. He will just talk to the examiner, answer him without thinking. And if you think for a while, you will waste the time and you will not find the answer. You might be also hesitant with your answer. So subconsciously, you should talk and you should answer the examiner immediately without any delay. This is the way how to answer the examiner, and you will get this confidence from any meeting. I not only my meeting, I encourage all to share with other mentor or with our meeting. But I'm talking in our meeting because I see more listener, but no one is active. I want all to be active, even for questions. If you have the confidence to ask, you will have the confidence to answer, to share. I'm not muting. I'm giving the all to be free to talk. Yes, some days I'm doing mute if I'm practice and there is some noise, but it's okay. I will open. If someone asks me to unmute him, I can mute him on here to talk. Please be free to talk and get the confidence to share with us your information. Yeah, in order to be more confident. Thank you all. I don't want to be more lengthy talking. We'll see you tomorrow. And tomorrow
Inshallah.
we'll have, yeah. Thank
Can
you,
I add
Dr.
something,
Tuba.
please?
Yeah, sure, sure.
Okay, so just I think we always will be like very overthinking about the differential, but I think it's really important to take the positive findings the patient give you seriously. For example, in this station, the patient said, I have overactive thyroid. I am not compliant with my medication. I have heart racing. So the first thing should come to our mind is like a differential diagnosis of like cytotoxicity complication. For example, we need to do ECG and exclude AF for this patient as a complication of cytotoxicosis. We need to advise him about compliance in the management. So this is like very simplest things, but we're always thinking about too much stuff, differential diagnosis of back pain. Most likely it will be osteoporosis. So we overthinking about to exclude as a DD, but we have here very main points we have to exclude like as a priority, right?
Yes,
Uh,
agree. Yes.
I just have a yes. I agree with you, doctor. Initially, this was a difficulty which I faced, honestly. Previously, before 2 months, if I look at myself, I was thinking same as you are talking right now. But thing is, when you start doing the cases, when you keep on practicing, you will start realizing that the thing which I need to rule out first, the surrounding structures. Whenever if it's a back pain, it's whether it's a, if let's suppose if somebody's give you the chest pain or somebody's give you the breathing difficulty, if the presenting complaint is breathing difficulty, there will be only two structures will be involved. There can be respiratory, there can be cardiology. So we have to exclude first these two. And if we talk about the back pain, then definitely we have to think the back first. Then we will move one by one to every structure, and then we will correlate. And ultimately, you will get some clue or some finding on history plus examination.
Exactly,
But
yes, as Dr.
key is
suggests.
practice. The key is practice. You have to get
Yes,
cases, you have to do random
yes,
cases, and you have to
yes,
talk for that cases, because you have
yes.
knowledge, and uh, that is most of the time it's sleeping behind the back. That knowledge
Mhm.
is sleeping, so we have to wake it up by just talking
Yes,
and by just practicing.
yes, agree. Agree with Dr. Suda in every word. Once you do practice, the case will be explored to you while examining, while taking history, while asking for the social, and you will not be hesitant and you will not be stressed if you didn't find the diagnosis while taking history and reaching to the minute, the last 2 minutes without reaching the diagnosis. Be sure if you didn't practice a lot or share with us or talk, you'll be more stressed whenever the time will pass and you don't know the clue for the case. And the stress will make you more stressed and you will lose the case. Why? Because you are stressed because you didn't practice before. But whenever you practice, you will find or you will face the case in one day with your colleague. You remember what you did, what you examined, and with the frequency of the practice, you will know how to do or how to deal with the positive finding and how to rule out other possible differential. That's why I'm encouraging all of you not to be only listener. Try to be active either by practicing or even by sharing or by asking, at least asking. Okay? Just take the confidence to talk. It's a matter of confidence, and in the exam you'll be more confident while the examiner is there and the more stress around you. Okay. Uh, thank you, Dr. Afaq, for your remind. And thank you, Dr. Suda, also for your share today.
No,
We'll
no,
see you
thank you
tomorrow.
so
If
much,
you
Dr. Basim, for
yeah,
giving so chances, and I will definitely be in touch with this group.
yeah,
Thank
Even
sure.
you
after
so
my
much,
exam,
Shukran.
I will definitely share my experience
Thank
after. Yeah,
you.
I have met,
Yeah,
inshallah. Thank you.
thank you,
Jazakallah,
Dr.
Jazakallah.
Suda.
Okay.
Yeah,
See you all.
and
See you. Oh, Allah.
inshallah, see you tomorrow.
Thank
Any
See
you.
you.
question? Yeah, thank you, Dr. Afaq. See you tomorrow, inshallah. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam.